Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Stand Medical Notes. Let's discuss the third acute complication of type 2 diabetes mellitus. Let's begin with the name of Almighty. Hypoglycemia is a critical time-sensitive physiological threat defined by a plasma glucose level low enough to cause symptoms. So you can take it as less than 70 milligram per deciliter. Okay. So hypoglycemia is defined by a plasma glucose of less than 70 milligram per deciliter, which causes symptoms. Now, ADA 2025 classifies hypoglycemia into three operational levels. So level 1, so mild, so less than 50 milligram per deciliter, but more than 54 milligram per deciliter, meaning 54 to 70 is level 1 class, mild hypoglycemia. What it means? Low blood glucose that may cause mild symptoms. So possible symptoms at this level include shakiness, sweating, hunger, irritability, palpitations, dizziness. Dizziness is also a symptom. Okay, 54 to 70 milligram per deciliter, mild hypoglycemia, which causes these symptoms, which can cause these symptoms. Now, moderate hypoglycemia is less than 54 milligram per deciliter. What it means? Low blood glucose that is more likely to cause noticeable symptoms and needs prompt action. Possible symptoms include confusion, weakness, blurred vision, headache, difficulty in concentrating. Okay, mainly CNS symptoms you will see here. Initial CNS symptoms. That means a patient who is having CNS symptoms, you should also check for blood sugar level. Hypoglycemia also causes hypoglycemia will cause CNS symptoms because our brain is 90% dependent upon glucose for working. Now the level 3 is severe hypoglycemia. Severe event requiring assistance, help. A severe event characterized by altered mental and or physical status requiring third party assistance for recovery irrespective of the specific glucose level. Remember, this point is very important. Okay, irrespective of specific glucose level. That means the patient may need assistance either due to altered mental or physical status test. So abnormality in the mental state or abnormality in the physical state can occur at any glucose level ranging from less than 70 to less than 54. So may it be any glucose level. If the patient needs assistance, needs help due to altered mental state or altered physical activity, that is classified as severe. Okay, so that's about 3 levels of hypoglycemia. So takeaway points are: low glucose can be dangerous. Recognize the level of glucose. If the patient does not need assistance, that means patient is in level 1 and 2. If he needs assistance either due to mental disability or physical disability, then that is level 3, meaning severe. Take action. First recognize the level, then take the action and get help if help is needed. Okay, so what's the pathophysiology? The human brain is obligatorily dependent on glucose. It cannot synthesize glucose nor store significant amounts of glucose. That is one point. Normal non-diabetic counter-regulatory response. When blood glucose falls, the body activates a coordinated defense to bring it up. Falling blood glucose, for example, what will happen? Insulin secretion ceases at approximately 80 milligram per deciliter. Insulin secretion ceases, and when the blood glucose reaches approximately 65 to 70, glucagon and epinephrine secretion will spike, promoting hepatic glycogenolysis and gluconeogenesis. Later, in minutes to hours, cortisol and growth hormone secretion will increase, that will induce peripheral insulin resistance. So initially the secretion of insulin will decrease, then secretion of glucagon and epinephrine will increase which causes glycogenolysis and gluconeogenesis, and then there will be increase in cortisol and growth hormone levels. that will produce peripheral insulin resistance, and that glucose will go to brain. So these are the mechanisms how our body counteracts hypoglycemia. Okay, first insulin secretion will cease, then epinephrine and glucagon secretion will increase, then again if it is not controlled, then cortisol and growth hormone will cause peripheral resistance. Now in insulin treated diabetes, defenses are dismantled. This is the problem. Exogenous insulin cannot be physiologically turned off when glucose levels drop. Many patients, long standing type 1 or advanced type 2, develop an absolute deficiency in the glucagon response to hypoglycemia. There is deficiency of the first response, that is glucagon response. Okay. Repeated mild iatrogenic hypoglycemia downregulates the autonomic nervous system's threshold for epinephrine release. This is known as hypoglycemia unawareness. Okay, so down regulation of, that means if previously our ANS was reacting to 80 milligram of blood glucose level, now it will be reduced to some 75 milligram of blood glucose. So repeated episodes of hypoglycemia will decrease the threshold of meaning decrease the level at which epinephrine should be released, the glucose level at which epinephrine should be released. So these are the principal hormones, glucagon and epinephrine. They are the first hormone. Late hormones are cortisol and growth hormone. So these are dismantled. These mechanisms are dismantled in patients with type 2 diabetes. Okay, that leads to hypoglycemia associated autonomic failure, commonly referred to as hypoglycemia unawareness. So these are the reasons for hypoglycemia unawareness. Why this matters? In patients with hypoglycemia unawareness, there will be no warning signs, initial warning signs, because the autonomic nervous system, the threshold of the autonomic system for glucose is increased. So lower and still lower glucose concentrations are required for the activation of autonomic nervous system. So you will not have any sweating, any palpitation, any anxiety. These are all features of ANS. Patient will directly land up in CNS symptoms, sudden progression to coma or seizure without any prodrome, without any warning sign. Okay, and this increases the risk of morbidity and mortality and fatal accidents, example while driving. So hypoglycemia unawareness, always think in elderly individuals who are having a long standing diabetes mellitus and repeated episodes of hypoglycemia. This should be kept in mind. Okay. Now, what are the clinical features, key signs and must not miss diagnosis? Clinical manifestations are classically divided into two distinct physiological waves depending on the depth of the glucose levels. So first there will be autonomic symptoms, adrenergic and cholinergic symptoms. Second there will be neuroglycopenic symptoms. So autonomic symptoms are triggered by epinephrine sympathetic surge. There will be sweating, pallor, resting tremor, tachycardia, profound anxiety, intense hunger. And one important practical point to say is, if a patient is taking beta blocker, then you will not have any autonomic signs, but one autonomic sign, that is sweating. So sweating will be preserved in patient who is taking beta blocker. So these other autonomic signs will be lost. This is one important point. So if you don't give glucose to this patient, then this patient will progress to neuroglycopenic symptoms. This is resulting from direct brain energy deprivation. What is that? Irritability, confusion, slurred speech, ataxia, impaired coordination. That means focal neurological deficits, making stroke, seizures, coma, death. That means any kind of CNS symptom, we should measure glucose level also. So we are learning from this, glucose has a very high role in having this CNS symptoms. So always measure glucose levels in a patient who is presenting with CNS symptoms: irritability, confusion, slurred speech, ataxia, focal neurological deficits mimicking stroke, seizures, coma, and death. Okay, that's about the symptoms. Must not miss diagnosis and triggers. So concealed pharmacological triggers like long-acting sulfonylureas, example glyburide or meglitinides, which stimulate endogenous insulin secretion independently of ambient glucose levels. So this can be the trigger. Patient may take medicines. Patient may have developed some nausea, vomiting, and he is not taking any food or any juice. Nothing he is taking. So, but the sulfonylurea which he is taking, it is acting upon. So he will develop hypoglycemia. Second important thing is beta blocker use. Non-selective beta blockers. Remember, non-selective beta blockers are notorious for masking the adrenergic symptoms of hypoglycemia, palpitations and tremor, leaving only diaphoresis, nothing but sweating. So sweating will not be masked by this beta blocker. This creates a treacherous diagnostic pitfall where the patient remains entirely unaware of the impending neuroglycopenic crash. So directly the patient will go to neuroglycopenic symptoms. Third is renal failure, very important point. Acute or chronic kidney injury dramatically prolongs the half-life of both insulin and renally cleared secretagogues like sulfonylureans, triggering unexpected and refractory, remember, unexpected and refractory hypoglycemia, which will not respond. Okay, refractory hypoglycemia. So these points are important to remember. So two triggers we should remember are most of the time it is due to missed meals. Hypoglycemia, the cause is missed meals. The patient will take insulin or the drug but no meals, or the patient will take more amount of insulin and less meals. So this is the most common cause of hypoglycemia. Second thing is chronic kidney or acute kidney injury, which will prolong the half-life of insulin or it will decrease the excretion of oral secretagogues. So this is very important point. So these two important things. Third point to remember is this is a pitfall actually. So beta blockers, non-selective beta blockers, they will mask the early autonomic nervous system except one symptom, that is sweating. Key takeaway is recognize the two waves of symptoms and be alert to hidden triggers. Early identification can prevent severe outcomes. So remember one thing, if you see a patient who was normal till recently and he is coming to you with repeated episodes of hypoglycemia and he doesn't have any history of taking less diet or increased dose in history of increased dose of his insulin or increased dose of his oral secretagogues. So a patient, an elderly patient coming with repeated hypoglycemic episodes with no history of increased insulin or oral hypoglycemic drugs, then you should suspect CKD in this patient, this kind of patient. CKD is in this kind of patient. This is a very important point. Okay. Now, so there are some drugs which also induce hypoglycemia like fluoroquinolones. A patient who is taking fluoroquinolones, notoriously this ciprofloxacin, levofloxacin, moxifloxacin even, and which is very much this gutifloxacin. So these all fluoroquinolones are very much known to cause hypoglycemia. They can cause either hypoglycemia or hyperglycemia, but a patient who is taking sulfonylurea, okay, and you give fluoroquinolone to that patient, so what that will do, it will decrease the metabolism of that oral secretagogue which the patient is taking. So what will happen, the patient will develop hypoglycemia. I have seen such cases that patient has gone to some quack and he has given him fluoroquinolone. Patient is having repeated hypoglycemic episodes. When I saw her drug box, then I saw levofloxacin drug in that for nothing purpose. There was no illness, there was no indication for antibiotic use. When levofloxacin was drawn, then there was no hypoglycemic episode. So that fluoroquinolones should be also kept in mind whenever a patient of type 2 diabetes mellitus who is taking oral anti-hypoglycemic drugs, then anti-hyperglycemic drugs, you should also have in mind that some drugs which produce hypoglycemia, notoriously this quinolone type of drugs. Okay. So what are the differential type of diagnosis? What are the other things which mimic hypoglycemia? When a patient with diabetes presents with altered mentation, hypoglycemia must be the very first consideration, evaluated immediately at the bedside. The differential includes other things which can be included apart from hypoglycemia. Hypoglycemia can be acute ischemic stroke or transient ischemic attack. Hypoglycemia can induce perfectly focal neurological deficits, example unilateral weakness or aphasia, that mimic acute stroke, rapidly resolving upon glucose administration. Okay, so the differential is, it can be a stroke also, it can be substance intoxication. Alcohol profoundly suppresses hepatic gluconeogenesis, exacerbating hypoglycemia and confusing the clinical presentation of intoxication. So a patient who is known to take alcohol, if he is having hypoglycemia, low blood sugar, then also always also think of alcohol induced hypoglycemia. Okay, because alcohol suppresses gluconeogenesis. Always this alcoholic liver disease patients, they will be developing this hypoglycemia because of this uh, suppressed gluconeogenesis. And it can be a post-ictal state. Suppose if the patient because of hypoglycemia has developed seizures, then how do you differentiate? So it can be post-ictal state also following an unobserved hypoglycemic seizure. So you need to differentiate it. If the patient is not a known case of seizures, okay, and he is a known case of diabetes mellitus, then you can think of maybe it can be due to hypoglycemia. And you may have a good blood sugar near to normal level. So whenever you have a blood sugar near to normal level, suppose for 100 like that, always remember this 100 level, 100 milligram per deciliter or 90 milligram per deciliter, this kind of blood sugar levels are actually absolutely normal in normal patients, but these are not normal blood sugar levels in diabetes patients. Actually these are warning blood sugar levels in diabetes patients, because these kind of blood sugar levels, random blood sugar levels 90, 100, these are giving indications to you that these patients are having a high dose of insulin either, or they are taking a high dose of oral anti-hypoglycemic drugs. So you should always suspect. So if a patient has seizure and you measured the blood glucose and he has 100, 105 or 110 blood sugar level, then you should think that it may be the seizure, may be the cause of the seizure, may be hypoglycemic episode. Maybe I am getting this 110 level because the counter regulatory responses may have started. Okay, so that thing also should be remembered. Fourth is endocrine deficiencies, concomitant Addison's disease or panhypopituitarism. Okay, Addison's disease. So this can be also be a cause, Addison's disease and panhypopituitarism. There the patient can have altered mental state. So these are all the differential diagnosis depending on the symptoms. So there are four. Patient can have, you need to differentiate from a stroke and TIA, substance intoxication, mainly alcohol or some other substance like opioid abuse or something like that. In India, very common is this organophosphate poisoning. Okay, substance intoxication. Then third one is post-ictal epilepsy. If the patient presents seizures, you need to differentiate. Okay, acute endocrine deficiencies like Addison's disease. So how you will know? So check the electrolyte levels. So if you have hypernatremia and hypokalemia, severe hypokalemia, or hyponatremia is a thing. Hyponatremia, sodium levels are important when CNS is concerned, because sodium levels will change the CNS state. So abnormality in CNS is caused by an electrolyte, that is sodium. So always check sodium levels in patients with altered mental status. Okay, so key takeaway here is always check bedside glucose first in any diabetic patient with altered mental status. Treat low glucose immediately while evaluating other causes. Meaning you should not think only in what do you call, in the way of glucose only. You should also suspect other cause also, because there may be some other cause which is concomitantly present with along with low hypoglycemia, low blood sugar, because low blood sugar levels is not only caused by this diabetes, it can be caused by some other thing like alcohol. Okay, or Addison's disease also, like that. Okay, so the key point is differential diagnosis is those differential diagnosis which produce focal neurological deficiencies, which produce seizures, and which produce altered sensorium. So these are the differential diagnosis. So how will be the diagnostic approach now? The diagnosis hinges on the rapid execution of a capillary blood glucose measurement, definitely formalized via Whipple's triad. What is Whipple's triad? It is a triad of three things. Number one is symptoms, signs, or both, which is consistent with hypoglycemia, like sweating, tremor, anxiety, hunger. Okay. Second is a reliable documented low plasma glucose concentration, that is less than 70 milligram per deciliter. So nowadays bedside automated glucose measurement instruments are present. You can measure. Second thing is you should have this second point. Third is immediate resolution of those symptoms or signs after plasma glucose concentration is reached. Symptoms present, glucose given, symptoms resolved. So if this Whipple's triad is fulfilled, then definitely the cause of definitely the cause of symptoms and signs of the patient is due to hypoglycemia. So you should have symptoms and signs which are consistent with hypoglycemia. When you measure, there should be low glucose levels, and when you give glucose, the patient should improve. Then that confirms then the patient was had symptoms because of hypoglycemia. This is known as Whipple's triad. Now nowadays the technology is very well developed. So a patient who is on CGM, continuous glucose monitoring. Okay. ADA 2025 guidelines emphasize the expanded use of CGM to detect asymptomatic hypoglycemia, particularly in high risk patients with autonomic failure, that is nothing but hypoglycemia unawareness in those patients. So how do you detect hypoglycemia in patients who is using CGM? By seeing this time below range, TBR. There is something known as time above range, time below range. Okay, time below range less than 4% is level 1 hypoglycemia, and time below range less than 1% is level 2 hypoglycemia. And if the patient has CNS symptoms, then that is level 3 hypoglycemia. So time below range less than 4% is hypoglycemia when CGM is in the context of CGM. Okay. CGM helps identify unrecognized lows, guide therapy adjustments, and reduce the risk of severe hypoglycemia. Okay. That's about the diagnostic approach. Now, what is the management strategy now? The therapeutic urgency is unmatched. Prolonged neuroglycopenia causes irreversible neuronal death. This should be kept in mind. So if glucose not given at correct time, then many neurons will die because they will not survive. Maybe in 4 to 5 minutes neurons are going to die. So there are two types of patients with hypoglycemia. There are conscious patients, so they don't need any aid, and there are some unconscious patients, or maybe they have altered sensorium, so they need aid. So this comes under level 1 and level 2. So in patients who are conscious, meaning level 1 and level 2, rule of 15 should be implemented. What is that? Give 15 to 20 grams of rapidly absorbed oral carbohydrates, like glucose tablets, 4 oz of juice, non-diet soda. Then recheck the capillary glucose in 15 minutes. If glucose remains less than 70 milligram per deciliter, then repeat what? Repeat again, you give 15 grams of carbohydrate, again wait for 15 minutes, again you check for capillary glucose. Okay, till it should come above 80 milligram per deciliter. You should do this thing. Okay, once normalized, provide a complex carbohydrate or protein snack to prevent recurrence. So initially you give direct glucose things. So when the glucose level normalize, you give carbohydrate or protein snack, a complex diet, starch diet you will give to prevent recurrence. So initially 15 to 20 grams of fast acting carbohydrates, wait for 15 to 15 minutes, recheck glucose, then provide complex carbohydrates and protein snacks. Target glucose is more than 70. So when you achieve this target glucose, give complex carbohydrates. In unconscious patient or inability to swallow, like level 3 patients, IV glucose should be given. So 50% dextrose in water should be given. So give 25 to 50 grams of dextrose IV push. So if there is no IV access, or so you can give 1 mg of glucagon, because glucagon raises the blood glucose level by glycogenolysis and gluconeogenesis, as we have seen. Okay, give 1 mg of glucagon either intramuscularly or subcutaneously. Intranasal glucagon formulation can also be used for bystander risk. Okay. Post resuscitation. Now you have post resuscitation care and the sulfonylurea trap. One point to remember is very important. Patients who suffered hypoglycemia induced by long-acting insulin or sulfonylureas require hospital admission and a continuous intravenous infusion of 10% dextrose. So sulfonylureas act for 24 hours. So if you give some amount of glucose now, but the sulfonylurea will continue to act. So that's why the patient should be admitted for 24 hours with this 10% of dextrose till the clearance of that sulfonylurea. Okay, that is one thing to remember. Now this algorithm: patient exhibits altered mental status or autonomic symptoms. Okay, and you have confirmed that it is due to low blood sugar. You have confirmed low blood glucose level. Now you will say, can the patient safely swallow, meaning patient whether he or she is in level 1, level 2. If he or she is in level 1 or 2, then you will give 15 to 20 gram of fast acting carbohydrates. If no, patient is in level 3, meaning he has altered sensorium or he is unconscious, then you will give initial IV push of 50 grams, 50% of D50 water, initial IV push. Okay, if IV access is not available, then you can give 1 mg glucagon intramuscularly or subcutaneously. Intranasal option is also available. Okay, now you will go to the cause. Whether the cause one thing should be kept in mind. Always we should think whether okay, in diabetes patient we are having hypoglycemia, but whether it was due to long acting sulfonylurea. If it was due to long acting sulfonylurea, then yes, then admit the patient for 24 hours and give 10% dextrose. No, then give a complex carbohydrate snack and adjust the outpatient regimen. This should be kept in mind. Okay. Special situations and pitfalls. Okay. Sulfonylurea induced rebound hypoglycemia. Sulfonylureas like glimepiride or glyburide bind to the ATP sensitive potassium channels on beta cells, causing continuous glucose independent insulin release. So in acute state, you will give D50 in water. There will be transient glucose spike. Stimulates more endogenous insulin release, leads to profound delayed rebound hypoglycemia. If you give just a acute D50, okay, acute fast acting glucose by IV route, and you leave the patient like that only, then there will be a delayed rebound hypoglycemia. So that is very dangerous because their half-life can exceed 24 hours. That's why close monitoring and sustained management are required. What is the management? After giving 50% dextrose, you give 10% dextrose infusion with close monitoring and occasionally the off-label use octreotide, somatostatin analog that inhibits the insulin release. Octreotide is a somatostatin analog which inhibits the insulin release. That also you can give in these cases. Okay. Now second is glucagon efficacy failure. Glucagon strictly relies on the mobilization of pre-existing hepatic glycogen stores. So glucagon is highly ineffective in malnourished patients. They don't have the store only. End stage liver disease patient, so again they will not also have store. They have suppressed glucose neogenesis, like in alcoholic liver disease patient, alcohol induced hypoglycemia. So in these three cases, the patient who doesn't have the store of glycogen, like malnourished patient who is having an end stage liver disease, patient having suppressed gluconeogenesis like alcohol induced hypoglycemia, their glucagon has no role to play. Okay, that's why you can't give in this patient. You need to give glucose only. Glucagon will not act. So ethanol metabolism will decrease this NAD plus. Ethanol metabolism depletes NAD plus, profoundly inhibiting gluconeogenesis and depleting glycogen stores. Okay, so liver patients and stage liver disease patients, alcohol patients and malnourished patients, glucagon you should not give for hypoglycemia. Now we will come to a practical case scenario, two case scenario actually. One is level 1 and level 2 and second is level 3. First case is mild to moderate hypoglycemia. A 62-year-old man with type 2 diabetes on insulin glargine 22 units nightly and glipizide 5 mg twice daily skips lunch and feels shaky, sweaty and hungry while working. So recognition symptoms, there are tremors, sweating, hunger, palpitation, anxiety, but patient is alert, able to swallow, vitals are stable, and you measure the blood glucose level, it is 54 milligram per deciliter. Step by step management, confirm, recheck capillary blood glucose, assess the severity and cause. If CBG is less than 70, then treat. Give rapid acting carbohydrate, 15 gram rule. So 3 to 4 glucose tablets or half cup of fruit juice or 1 tablespoon of sugar. Okay, these are all 15 grams of fast acting carbohydrate. 4 glucose tablets or half cup of juice or 1 tablespoon of sugar or 1 tube of glucose gel. Okay, easiest one is this one, 1 tablespoon of sugar or half cup of glucose. Then recheck in 15 minutes. Okay, still the glucose level is less than 70. Once the CBG is more than 70 milligram per liter and symptoms improve, give a snack or meal with complex carbohydrate and protein to prevent recurrence, like whole grain bread, peanut butter, milk, yogurt, nuts. Okay. Now the fifth thing is identify and correct the cause. That is the last thing. Either whether the patient was missing the meals, or the patient is taking excessive insulin or sulfonylurea, or it is because of excess exercise, or the patient has taken alcohol. So alcohol is also an important cause. Titration of therapy after recovery. Adjust the diabetes therapy to prevent recurrence. If hypoglycemia was due to sulfonylurea, reduce the dose. Glipizide 5 mg BD reduced to 2.5, half the dose. If it was due to glargine, then reduce the total dose from 20 to 18 units will reduce, 20%. Okay. Prandial insulin, reduce the pre-meal dose from 6 units to 4 units, 2 units will reduce. Both basal and prandial reduce both doses. Basal 10 to 20% and prandial 10 to 20%. Okay. Goal is to maintain blood glucose between 90 to 130 before meals and CBG less than 120 after 2 hours after meals, and there should be no recurrent hypoglycemia. So that's about the case of level 1 and level 2. So at last we'll see the cause. Then coming to a case with severe hypoglycemia. A 58-year-old woman with type 2 diabetes on premixed insulin, 30 units premixed insulin. Okay. BD is found drowsy and confused at home. She is not able to swallow. Blood sugar level is 32. So altered consciousness is there, seizure is also there, and the patient is also unable to swallow. Blood glucose is less than 54, medical emergency. See airway, breathing and circulation first, ABC. Then check response, meaning CNS, airway, breathing and circulation. Check CBG and call for help. Now, if no IV access, give glucagon immediately. Glucagon 1 mg IM deltoid or subcutaneous. Turn patient on side, recovery position. So either you can give glucagon or you can give dextrose. So dextrose 25% solution 20 ml IV bolus or 50% 10 ml IV bolus you should give. If CBG is still less than 70 after 10 to 15 minutes, then repeat the 25% 20 ml IV or 50% 10 ml IV bolus. Then follow up is you give a long acting 10% dextrose infusion at a rate of 100 to 150 ml per hour, meaning 100 ml per hour. Okay, and adjust the rate of that infusion so that the blood glucose level lies between 100 to 180. Monitor and support. Monitor the blood glucose level every 15 minutes until stable, then hourly. Assess vitals, oxygenation, ECG if needed. Look for and treat the underlying cause. Once conscious and able to swallow, give oral carbohydrate. So from IV you switch to oral carbohydrate, then that should be followed by a snack and meal. Titration of therapy after recovery. Reduce intensity and prevent recurrence. So what is the cause? Usually if the patient was on pre-mixed insulin 70-30 or 75-25, reduce the total dose, okay, by 20%. If it is because of basal insulin, reduce the total dose by 20%. if the patient is taking multiple injections, reduce the baseline prandial dose by 10 to 20%. Okay, goal is to have the current glucose level between 100 to 180 while in hospital and prevent recurrence of severe hypoglycemia, save discharge with revised plan and education. Okay, so now key points for both scenarios. Always check CBG when symptoms suggest hypoglycemia. Treat promptly. Brain depends upon glucose. Reassess, recheck and prevent reoccurrence. Educate patient and caregivers. Discharge plan is review medications and doses, regular meals, avoid skipping of meals, carry fast acting glucose, follow up in 1 to 2 weeks. When to seek help? Recurrent episodes if the patient is having inability to maintain CBG of more than 70 mg per deciliter, seizures or any severe symptoms, seek medical attention. So like this cases only patient may have CKD. Okay, normal glucose level is fasting 70 to 100, postprandial is less than 140 per hour, hypoglycemia is less. But remember, when a type 2 diabetes mellitus patient comes to you and maybe he is having some CNS malfunctioning like in the form of seizure or focal neurologic deficit, and his patient or her patient is her glucose is 110 or 105 something like that, then the cause may be hypoglycemia only because of missed meals or increased dose of insulin or anti-hyperglycemic drugs. Okay, thank you.